Good afternoon, dear colleagues. My name is Gernot Hudelist from Vienna. I'm a reproductive surgeon and consulting gynecologist. And I am honored and delighted to be with you and would like to say thank you for inviting me to this extraordinary, interesting meeting. And my task today will be to give an overview on the surgical treatment options for ovarian endometriosis. You may hear different aspects from my colleagues in this session. It may well be that we might overlap a little, but first and foremost, I would like to look at the three main tasks of this presentation. First and foremost, it's important to know whether we're actually dealing with an endometrioma. Secondly, I would briefly like to discuss the indications for ovarian endometrioma surgery. And finally, and most importantly, look at the techniques. Are there superior ways to surgically treat endometriosis affecting the ovary? So I think that is of utmost importance to be aware of what you are dealing with. And I would highly recommend you to use the IOTA guidelines, which are referred in a recently published consensus statement on the preoperative diagnosis of ovarian tumors, clearly stating that ovarian lesions, ovarian cysts, ovarian tumors should be categorized and estimated regarding the potential of malignancy. And as you can see, ovarian endometriomas are typically uni or bilateral, uni or multilocular cysts. The number of locals rarely exceeds 3 to 4. We do have a ground glass content, and in about 1/10 there are papillary structures. However, they are not typically mushroom-like. They're not perfused like in ovarian malignancy, and they are mostly amorphic content caused by the cyst content and the blood clots in the endometriotic cyst. However, we should be aware that ovarian cancer may arise from endometriomas, and in case of papillary projections which are perfused, we are very, very obliged to make sure not to cause spillage and possibly change the stage of ovarian cancer in case of spillage caused by the attempted cystectomy. So, secondly, I would like to briefly discuss the indications for endometrioma surgery. And I think there are three main constellations. First, we would do endometrioma surgery for pain patients. Is it effective? Will the surgery decrease the pain? What about ovarian endometriosis in the non-infertile patients, especially in asymptomatic patients? And finally, what about treating ovarian endometriosis in the subfertile or infertile patient? So there is a quite good body of evidence clearly stating that in a patient with symptomatic endometriosis, resection of ovarian endometriosis will relevantly decrease pain symptoms. However, in reality, the majority of these pain patients or symptomatic patients will exhibit additional peritoneal or even deep infiltrating lesions. So we are not purely dealing with ovarian endometriosis. In the cohort of patients which purely exhibits ovarian endometriosis, symptomatic patients have to be encountered in about 40%. So, do we have to treat patients who are asymptomatic? And do we have to treat patients who may exhibit endometriomas as a result of a routine examination? And we have to bear in mind, and I highly recommend to read the paper by Professor Maggiore, which I think is really highly interesting, that the rate of ovulation is not relevantly affected in the affected site, affected by ovarian endometriosis. And if we look at patients with ovarian endometriosis, the pregnancy rate in non-treated patients, the cumulative pregnancy rate over a period of 6 months even reaches 43%. There are differences between purely ovarian endometriosis and additional deep infiltrating endometriosis, where spontaneous pregnancy rates drop, but in patients with purely ovarian disease, pregnancy and spontaneous conception over 6 months is absolutely expectable and may be recommended. The question is whether we do miss something by not treating these patients. And this paper has shown that the mean increase in diameter is around 4% over a period of about 6 months, which is possibly neglectable. So expectant management may and will be a treatment option in these patients. What about endometrioma surgery in the infertile patients? And there are two scenarios. The one scenario is the patient who will go into IVF for whatever reason. And there is a large body of evidence showing that the surgery for the endometrioma pre-IVF will not relevantly significantly increase live birth rates. However, there are patients where follicles will not be accessible, and there may be patients who are in severe quality of life reduction pain. These patients may benefit from ovarian endometrioma surgery before IVF. The other scenario is the patient who aims for a spontaneous conception. And here, ovarian cystectomy relevantly increases post-interventional pregnancy rates up to 40-50%, with a number needed to treat around 2 to 3. So these patients may or will benefit from a surgical procedure. To come to the main task of this presentation, I would like to attempt to answer the question whether there is a superior technique, and this is very, very difficult. And the more I got into this subject, the more difficult it proved. And I think we should be aware of 3 facts before embarking on this discussion. First, I think it is important to know that endometrioma surgery may lead to a bigger decline in AMH levels than surgery for other pathologies like dermoid cysts, etc., etc. But, however, we should also be aware that the endometrioma per se may reduce the basic AMH by about 1 nanogram per milliliter. So endometrioma as such will also already cause a decrease in AMH levels. Secondly, the decline of AMH, which will always be present in endometrioma surgery, is especially to be expected in large endometriomas above 7 centimeters in diameter. And finally, in patients with bilateral endometrioma, this decline is even more pronounced compared to patients with unilateral endometriomas. So let's look at the techniques. And of course, there is cystectomy, there is ablation with bipolar energy, there is laser vaporization. And looking at all these treatment options, the current major guidelines like ASHRAE primarily recommend cystectomy for treatment of ovarian endometriosis. Why? Because there is a large body of evidence that it decreases pain symptoms long-term more pronounced than other techniques, and because the current body of evidence shows that cystectomy confers higher pregnancy rates compared to fenestration and ablation, and also TUC laser vaporization. And cystectomy may, in the head-to-head comparison, entail even higher spontaneous pregnancy rates compared to CO2 laser vaporization. However, a recent study by Candiani shows that this difference between cystectomy and CO2 laser does not significantly appear to be changed if we look at overall pregnancy rates. So cystectomy is an effective treatment option for ovarian endometriosis. But should we treat all patients with cystectomy? And we have to be aware that cystectomy entails a detrimental effect on ovarian tissue, especially in patients with bilateral disease. And the parameter to be looked at in most of the studies is AMH. And looking at AMH levels, the drop following 6 weeks post-surgery and at 6 months reaches 30 to 40% of the baseline value. So we have to be aware that endometrioma surgery by cystectomy will cause ovarian tissue damage. So why is that so? And the killer for ovarian tissue is the combination of cystectomy and bipolar energy. And this meta-analysis by Atta and Orman from Koç University in Turkey clearly demonstrates, nicely demonstrates, that bipolar energy should be avoided wherever, if ever possible, because it is clearly inferior to any hemostatic sealant, to suturing following cystectomy, and it will cause the largest drop in AMH levels if we combine cystectomy with bipolar coagulation. So what should we do? And yes, cystectomy may be the treatment of choice, but I think we have to consider different scenarios. The drop in AMH is, as we have said, even more pronounced in large endometriomas. It is even more pronounced in bilateral endometriomas. And knowing that AMH levels may be dropping less significantly in laser vaporization patients. And this is a recent paper, Pakandiani et al., showing that the drop in AMH was about 1 nanogram per milliliters less in laser vaporized patients compared to cystectomy patients, although the pregnancy rate was similar or even higher in cystectomy patients. We should be aware of the fact that the combination of cystectomy plus certain basic situations or parameters like large cyst, bilateral cysts, or possibly recurrent disease may be especially detrimental. So what should we do? And I think the possible strategy could be that, yes, the current evidence supports the use of cystectomy, but we should be aware of the basic MH levels. We should be aware of the age of the patient, on the fact that it's either uni or bilateral disease, whether there is additional deep endometriosis, adenomyosis, or whether it's recurrent disease. And these patients may have a detrimental effect by treating them with cystectomy, especially when we combine it with bithermal energy use. And these patients should be regarded as candidates for alternatives, such as sclerotherapy, possibly or ideally CO2 laser vaporization, or even ablation in bilateral endometriomas in order to avoid a reduction in fertility and AMH levels. So coming to the conclusion, I think that first, it's important to know what you're going to get. Are you really dealing with an endometriomas? Is there a possible suspicion of malignancy? If yes, cystectomy should be clearly avoided. Which patients do we need to treat? We should know that expectant management of ovarian endometriosis may be a viable treatment option in patients seeking a pregnancy who are not infertile. If we do treat infertile patients going into IVF, there is no relevantly proven advantage unless the follicles are not accessible or they got severe pain problems. In patients seeking a spontaneous conception, post-interventional pregnancy rates exceed 40%, and it is relevantly and may make sense to operate these patients. The superior technique is the big question sign. Cystectomy may be highly effective regarding pain reduction and fertility outcomes, but it may also be detrimental and cause relevant ovarian tissue damage, especially in older patients, especially in patients with low MAH levels, especially in patients with bilateral endometriomas, especially in patients with large endometriomas, especially in patients with recurrent disease. Knowing that CO2 laser vaporization has similar outcomes fertility-wise and may be combined with low MH drops, knowing that sclerotherapy, which has been already discussed, may be a treatment option, cystectomy should possibly be avoided in these patients. And I would like to thank you for your attention, and I'm looking forward to a discussion. Thank you very much.